hypertension is. So the learning objectives, we're going to define the stages of hypertension, the management strategies for patients with hypertension. We're going to look at resistant hypertension and how to treat these patients. First, how to make the diagnosis of resistant hypertension. There's a specific diagnosis for that. Then we're going to look at the more common secondary causes for hypertension and how to treat these individuals. A lot of our patients with secondary hypertension fall through the crack because we don't search for it. And then we're gonna wind up our lecture series with hypertensive crisis, patients with malignant hypertension, and how to manage these individuals. So usually would give this lecture in a 45-50 minute clip, but I think it's a real injustice to individuals if we just rush the lecture. So I'm going to take my time to develop the guidelines, go through very basic things, and then we can go into the more more challenging areas in terms of making certain diagnosis and management. All right, so what I'm going to be discussing is the 2017 hypertension clinical practice guidelines, and this came out in November 2017, November 13, 2017. I think it's in JACC, Journal of American College of Cardiology, and commonly referred to as the ACC/AHA task force. So the guidelines should replace clinical judgment. And the thing about it, if you don't follow guidelines, you can run into problems in terms of malpractice. Later on in the lecture, I'm going to go over things like the class of recommendation and the level of evidence, because when we prescribe any type of treatment or procedure, we usually refer to the class of recommendation, and then the class goes from class 1, class 2, and class 3. Class 1 is you definitely should, once a patient satisfies the criteria, then it's a class 1. Class 2, you can do it. Not a lot of evidence to support it, but you can do it if it's going to benefit the patient. Class 3 is a contraindication, but we'll go over that. From the 1920s, however, there were studies showing strong relationship between blood pressure and complications and death. So from the 1920s or before, we know that hypertension was a bad thing. In the 1960s, we confirmed that with the Framingham Heart Study in Massachusetts. And we even have the Framingham offspring studies, which confirm a lot of this. The Veteran Administration Cooperative studies in 1967 and 1970 also show the effectiveness of treating blood pressure. The National Heart, Lung, and Blood Institute did the first comprehensive guideline for detection, evaluation, and management of hypertension in 1977. So we've been, talking about hypertension for quite some time, but the JNC, which is the Joint National Committee, published their guidelines a number of years, and we have been using the JNC guidelines, the Joint National Committee guidelines, and we moved from JNC 1 straight up to JNC 8. So before this guideline came out, we had JNC 8 up to JNC 8, Joint National Committee. when we look at when we look at meta-analysis of multiple studies, what these meta-analysis shows us is that hypertension is associated with cardiovascular disease risk. There is a risk of developing cardiovascular disease with hypertension. And if you have like a systolic 20 millimeter increase in blood pressure or a diastolic 10 millimeter increase in blood pressure, it results in a doubling of cerebrovascular accident, heart disease, and other vascular disease. So what we're saying is that hypertension is a very strong risk factor for coronary cardiovascular disease. Okay, so it's one of the leading cause of death and disability, and worldwide, and that was shown in 2010. It accounts for more cardiovascular disease death than any other modifiable cardiovascular disease risk factor. And when we talk about modifiable, well, we'll go into that. But just to go over, for people who gonna measure blood pressure, you have to follow the guidelines. Make sure that everybody is doing blood pressure measurements the same way. So the systolic blood pressure is usually the first Korsakoff sound, and the diastolic blood pressure is when you have the absence of the Korsakoff sound. So they say the fifth Korsakoff sound, which is really the absence of the Korsakoff sound. And then some definition, pulse pressure is the difference between your systolic blood pressure and the diastolic blood pressure. The mean arterial pressure is the diastolic pressure plus 1/3 the pulse pressure. And then there's something they call the mid blood pressure. So the mid blood pressure is just a sum of the systolic and the diastolic divided by 2. When you're doing blood pressure, when we give a blood pressure, we should give a heart rate, because we assume what we're doing is at a normal heart rate. But as you know, most of the time when we do vital signs, we do the heart rate. So the modifiable risk factors. So when the risk factors that are common with hypertension, the modifiable risk factors: cigarette smoking. If you can convince someone to stop smoke, or secondhand smoke, you can move away from the smoking area. So these are modifiable risk factors associated with hypertension. Diabetes can be treated. Dyslipidemia, hypercholesterolemia, overweight, obesity, physical inactivity, low fitness, and unhealthy diet. So we're gonna look at diet, because diet is crucial. Diet is very, very crucial in hypertension and cardiovascular health. So we're gonna spend some time going over diets. And these are some relatively fixed risk factors: chronic kidney disease, family history, increased age, low socioeconomic and education status, male sex, obstructive sleep apnea is big. You know about obstructive sleep apnea, psychosocial stress. So what I'm also going to do, because all exams have tremendous questions related to hypertension. I did the cardiovascular research a little more than a year ago, and it was loaded with questions about hypertension. So even at that level, they want to make sure you understand the basic things about hypertension. So about 71% of our diabetic patients have hypertension. Close to 3/4 of our diabetic patients have hypertension. When we talk about patients with chronic kidney disease, about 86% of those patients have hypertension. And if you have a combination of chronic kidney disease and hypertension, 28.1% of those patients have what we call resistant hypertension. And we're going to go over the definition of resistant hypertension, how to treat these patients. What about obesity? 35.7% of patients who are obese have hypertension. So these are the new guidelines. So this is what everybody should be following. And we're not gonna mention anything about JNC 8, even though the last joint national committee was JNC 8. JNC 8, to be honest with you, was a disaster. So it is not mentioned in the literature anymore. So we'll make reference to JNC 7, but this is the current guidelines. So there's a normal blood pressure is a systolic blood pressure less than 120, and a patient individuals who are doing exams. So you need to know this, okay? Because these are the guidelines. This is from 2017, so they expect you to know this. So a normal blood pressure systolic less than 120 and diastolic less than 80. There's a category they call elevated blood pressure, and the systolic between 120 and 129 millimeters mercury, and diastolic less than 80. So this is elevated blood pressure. Then when you come to hypertension, there are two stages. You have stage 1, systolic 130 to 139, or diastolic 80 to 89. And then stage 2, systolic greater than or equal to 140, or diastolic greater than or equal to 90. Now, what you have to do is you're going to stage the patient using the highest blood pressure. So say, for instance, the patient presents with a blood pressure of, say, 117 over 90. The highest, so the 117 systolic is a normal, but the diastolic 90 is going to put them in a stage 2, okay? So their hypertension is stage 2. So you're going to stage them using the higher pressure. So if they have a systolic of 150 and a diastolic of 70, yeah, the diastolic is normal, but the systolic is 150, which is going to put them in stage 2. Okay? So individual with systolic and diastolic blood pressure in 2 categories should be designated to the higher blood pressure category. Okay? So be aware of that. And when you're doing blood pressures, you want to get more than 2 readings, but not at the same time. Not at the same time. We used to just, separate the time, a few minutes, not at the same time. They recommend that you need 2 or more readings, yes, but on 2 or more occasions, so not at the same time. Okay. So those are the current breakdown. So there's a elevated blood pressure category, and then you have the stages of hypertension. What about the lifetime development of hypertension? So the MESA study, which is the multi-ethnic study of atherosclerosis, look at the lifetime development of hypertension. It was higher for African Americans, for Black patients, and Hispanics as compared to whites and Asians. And we've been saying this over and over: Black patients and Hispanics tend to have more hypertension. When you look at adults age 45, so adults age 45 without hypertension, their 40-year risk of developing hypertension is 93% for African Americans, 92% for Hispanics, and 86% for whites. So it looks like everybody is going to get hypertension, all right? Because it's so prevalent. And when you look at the Framingham Heart Study, if you're free from hypertension at age 55 or 65, you have a 90% chance of developing hypertension during your lifetime. Hypertension is very, very common, is very frequent, very prevalent. But with the current guidelines, the JNC 7, which we you know, the hypertension was blood pressure greater than 140/90. But the 2017 guidelines, which say that the blood pressure is elevated if it's greater than 130/80, that put about 46% of the population in the hypertension category. And as we have said before, hypertension is, the older you get, chance of developing hypertension increases. It's greater for Black patients and Hispanics as compared to white. Now, when we talk about blood pressure measurements, we talk about office blood pressure measurements and out of office. So there's a lot of error in doing office blood pressure measurements, and we need to be aware of those so that we don't, fall into those categories. So what we use is basically the oscillometric devices. We blow up a balloon and it squeezes, they occlude the blood vessel, and we gradually release the pressure and we measure the pressure. So this is what we do. But what's the proper way of doing it? Because as we said, there's a lot of error in how we measure pressures. So basically, when the patient come to the office, you should have the patient relax, sitting in a chair with the feet on the floor. The back should be supported, okay, for at least 5 minutes. You should avoid caffeine. The patient shouldn't be exercising. Smoking cessation for at least 30 minutes before the measurement. Ensure that the patient empty their bladder, they're not uncomfortable, and you shouldn't be talking to the patient, okay? Remove all clothing covering the limb that you're going to measure the pressure. So I've gone to facilities and I've seen the patient have a long sleeve shirt and they just put the stuff, that you shouldn't do that because you're going to get erroneous readings. So remove all clothing covering the location of cuff placement. The measurement should be made while the patient, so you shouldn't have the patient lying or sitting in such a way that their feet is not on the ground, and their arm should be rest on some, a desk or something like that. So, and then you're going to use your BP device that has been validated. So periodically, you're going to calibrate your device. Again, the patient's arm should be on a desk, rested properly. You're going to position the middle of the cuff on the patient's upper arm. Make sure you use the right size cuff. That's a very important error as well. So these are some little things that we tend to neglect at times, okay? At the first visit, when the patient comes to see you at the first time, do blood pressure in both arms. Do blood pressure in both arms. And the one that gives you the highest reading, that's the arm you're going to use when the patient comes to see you in subsequent visits. In doing the blood pressure in both arms initially, rarely you might pick up a coarctation or a dissection or something like that. Not very common, but if if your practice is such, you may pick up a patient with coarctation of the aorta. If you're going to repeat the measurement, wait about 1 or 2 minutes. You can use the palpation methods where you inflate the cuff above when you obliterate the radial pulse. So you inflate the cuff when the radial pulse is obliterated, then you inflate it about 20 to 30 millimeters mercury above that level, and then you gradually reduce it. For people doing the exams, so you're gonna do your deflation at a rate of 2 millimeters per second, okay? And you're gonna listen for the Kharkov sounds, okay? Then you're gonna record your systolic and diastolic blood pressure. Remember, the systolic first Kharkov sound, and then when you have disappearance of all the sounds, then that's your diastolic pressure. And again, you know, greater than or equal to 2 recordings obtained on 2 or more occasions. So remember that that's testable, I think. And all right, so you have different size cuff. If it's a small individual, you know, you can use 26 centimeter circumflex, small cuff, average size adult or large adult. So remember that you have to use the proper cuff. And then not only that, a lot of these patients are going to have home devices. So when they get a home device, you have to let them bring it to the office, because they have to have a proper size cuff, lest they're going to give you erroneous readings at home as well. So there's tremendous problem with office readings in terms of how it's done. But if it's done properly and you want to validate a lot of the pressures that you get in office, then you can do out of office blood pressure monitoring. And one of the out of office monitoring is the home blood pressure monitoring. So the patient should be trained how to do this. So you give them a quick overview of what hypertension is and how to manage it. You know, it is a risk factor for cardiovascular disease, you know, stroke, kidney failure, stuff like that. So and then you show them how to monitor the blood pressure. See, just how you do the pressure in the office, that's how they should do it at home. They should be relaxed, not in a noisy environment. They shouldn't be talking to a bunch of people when they're doing it. The feet should be on the ground. The arm should be rested on a desk, and the arm should be at the level of the right atrium. So the same thing that you do in the office, that's the same thing they should be doing at home, so that you can use the readings that they're getting from home to make certain management decisions. You're gonna let them use a digital device, because you don't want them to use the auscultator method. That's not. So the same thing that you do in the office, you know, no smoking, no caffeinate, no exercise, sit down, relax. So the same thing they should be doing at home. And let them, if it's a device that have a recording, you can let them record the pressures. If it does not, then let them write it down. Okay? So that is your home blood pressure monitor. We have another device we call the ambulatory blood pressure monitoring. So there are 2 out of office devices, the home and then the ambulatory. So with ambulatory, you can do 24-hour blood pressure recordings. But you know, it's customary during the day, you want to assess the pressure every 15 to 30 minutes throughout the day, and at night a little bit less, probably every 15 to 1 hour. And you will get a mean nighttime blood pressure recording. You can also get a mean daytime blood pressure recording, and you can identify early morning blood pressure surge, so you can see certain trends, what's happening during the night, what's happening during the morning and throughout the day. And you can look at blood pressure variability. So the ambulatory blood pressure monitoring is it's a very good device. So again, patient may tell you that they're lightheaded and dizzy a certain time of the day. You can correlate that and see if they're hypotensive during that time, okay? Or you can look at daytime to nighttime blood pressure ratio to determine if there's significant nocturnal dipping in the blood pressure. So you can get a lot of information from your ambulatory blood pressure monitoring. There's a meta-analysis looking at some observational studies with 13,000 plus patients, which suggests that the nighttime blood pressure is a stronger risk factor for cardiovascular heart disease. Okay, so nighttime blood pressure in this meta-analysis was a stronger risk factor for cardiovascular heart disease, stroke. So, but one of the most important information that we get from out of office blood pressure monitoring is the assessment of white coat hypertension. So what is this white coat hypertension? So the patient comes to the office and the blood pressure is high, and it's always high when they come to the office. Is the blood pressure elevated at home as well? So you can use your out of office blood pressure assessment to determine that. So if you have elevated office blood pressure, but when they do out of office measurements, so ambulatory or the home blood pressure monitoring, if that's normal, then that's what we call white coat hypertension. And usually the office pressure is usually about 20 systolic, about 10 diastolic higher than the home pressures. Okay, so this is your white coat hypertension. That's the definition. There is a condition called mass hypertension. And then people who are doing exam again, this is probably a relative new concept for you, so you need to understand that. So the mass hypertensive patients, they come to the office and their blood pressures are normal. But when you evaluate these patients, you realize that they have ophthalmic changes suggestive of hypertension. You do your echocardiogram, they have LVH, they have kidney failure, and they may have had a stroke. But for some reason, whenever they come to the office, the pressure is normal. These patients are having significant hypertensive situation outside of the office, which cause target organ damage. So the definition of mass hypertension is normal pressures in the office, but these patients have target organ damage. They may have had a stroke, they may have had a bump in their BUN and creatinine. So it's reasonable to send these patients home with out of office blood pressure monitoring with ambulatory or home blood pressure monitoring. Okay, and what you will see is that these readings are consistently above normal. And it is said that about 10 to 26% of patients of the patients in the population may have this mass hypertension. So, what's going to drive you is that pressure is good, but they still have target organ damage. Okay, so and then we have the sustained hypertension where the blood pressure recordings is elevated in the office and out of the office settings. So little chart. So a normotensive individual going to have out of office blood pressure, which is normal, and then out of office, which could be home blood pressure or ambulatory, which is no hypertension. Then the sustained, they're going to have office and out of office hypertension. Your mask is the one who have office, which is no hypertension. But when you monitor these patients at home, they're hypertensive. And then the white coat hypertensive in the office, normal pressure at home. Okay, so those are some important hypertensive features that you need to be aware of. And then especially people who are doing exams, they like those little things. So what are some of the causes of hypertension? We know that there's a genetic predisposition to hypertension, but it's varied, and it's a very polygenetic type of thing. So because almost everybody have hypertension. But most of the hypertensions is secondary to environmental factors. We commonly refer to patients as essential hypertension or primary hypertension, but a lot of our so-called essential hypertensive patients or primary hypertension, these patients are overweight, they're obese, excessive sodium intake, physical inactivity, and alcohol consumption. So these are some of the things that we need to pay special attention. And when we talk about lifestyle changes, these are what we're talking about. Okay, so one of the first step in treating hypertension is lifestyle changes, and we talk about the dietary and the overweight individual excess sodium intake. Because remember, salt is in everything, and then we eat a lot of preserved stuff which contains sodium, physical inactivity, and alcohol consumption. So what about our overweight and obese individual? So there have been a direct relationship between overweight, obesity, and hypertension. We have recognized this for years. We know that the body mass index and blood pressure is there's a direct correlation there. However, there's a strong relationship to the waist to hip ratio. Okay, so the waist to hip ratio, especially in males. Okay, and if you do your CT measures of central fat distribution, that's also correlates with hypertension. So your obese individual or overweight individual may be responsible for as much as 40% of hypertension. So we commonly talk about essential hypertension, but if we can control the weight reduction, we can reduce some of these hypertension. So 78% of male and 65% of female who are obese from the Framingham Offspring study were shown to be hypertensive. Sodium, salt intake. This accounts for a significant proportion of hypertension, especially in Black patients. Okay, there is excessive consumption of sodium, and it is independently associated with increased risk of stroke, cardiovascular disease, and other cardiovascular problems. So sodium intake is one of the main problems in hypertension. There's increased salt sensitivity in blacks, older adults, patients with chronic kidney disease, diabetic, and patients with metabolic syndrome. Salt sensitivity. Okay, so what about potassium? We know that potassium intake is inversely related to blood pressure. So the higher the potassium, the lower the blood pressure. It's also inversely related to strokes, and it blunt the effect of sodium and blood pressure, and it decreases the sodium to potassium ratio, and that may result in reduction in cardiovascular disease. However, we're talking about dietary potassium. We're not talking about potassium supplements. So potassium is good, but the dietary potassium. Alcohol, from 1915, we know that there was a direct relationship between alcohol consumption and blood pressure. Okay, alcohol is bad. It accounts for about 10% of the hypertensive burden. Okay, it does some good things. However, remember Alcohol in moderation increases the HDL cholesterol, and it lowers the level of cardiovascular heart disease. Okay, so it does some good things, but excessive alcohol will give rise to hypertension. As we said before, if we look at kids, um, you know, kids who have higher blood pressure usually go on to develop hypertension. Say there's a genetic factor, obese kids will develop, if their blood pressure is elevated, they'll develop future blood pressure. Premature babies and babies with lower birth rate is associated with later hypertension. So this is a very important association: premature birth and lower birth weight babies. So there, as we said, there are other environmental stuff that can give rise to hypertension. You know, so when the patient comes to the office, find out what they're taking, even if it's over the counter herbal, because a lot of these things are associated, can elevate the blood pressure. Even if it's prescription medicine, find out what they're taking, you know, over the counter stuff, illicit drugs, a lot of illicit drugs and herbal products. So these are a lot of stuff, you know, illegal, herbal, that can elevate the blood pressure. When we talk about alcohol, we usually say that for females, they should have one or less than one drink per day. And for males, 2 or less than 2 drinks per day. So, you know, what is a drink? And what is a drink is it should contains less than 14 grams of alcohol in the drink. So for a beer, which is 5% alcohol, we're talking about 12 ounces. For wine, which is about 12% alcohol by volume, we're talking about 5 ounces. And then for hard liquor, you know, it's about 40%, 1.5 ounces. So for females, less than or equal to 1 drink, and males less than or equal to 2. But these are some of the stuff that can elevate blood pressure: amphetamines and amphetamine products, antidepressants, the MAO inhibitors, serotonin, norepinephrine receptor uptake inhibitors, tricyclic antidepressants. So these are prescription medication and they can elevate the blood pressure. Antipsychotics such as clozapine, olanzapine, caffeine, excessive caffeine though. So you want to stick to less than 300 milligrams per day. Some decongestants, phenylephrine, pseudoephedrine, herbal products such as St. John worts and this mahuang, which contains ephedra. And then people who are doing exams, the immunosuppressive cyclosporine. So they love this in exam for whatever reason. Patient is on, blood pressure was pretty good. They had, say, a heart transplant, and they were put on this. The blood pressure is now elevated, and you know, so cyclosporine is a relative. Oral contraceptives, NSAIDs. A lot of patients having arthritic pain, and they're put on NSAIDs, which elevate the blood pressure as well. So recreational drugs, bath salts, cocaine, methamphetamines, steroids. Remember, if the patient's taking steroids, that can elevate blood pressure. And these angiogenesis inhibitors. So these are some common over-the-counter, some of them over-the-counter, some of them herbal substances that can elevate the blood pressure. So as promised, I'm going to stop here because we don't want it to be too exhaustive, okay? But it's important to get this basic understanding so that when we start to look into more complex things, you understand the basics, okay? So we'll have about another 2 or 3 lectures to look at the whole aspect of the 2017 guidelines, okay? All right, so thank you for joining, And the next session will be Thursday at 9 o'clock again. Okay. All right. So what we'll do, we'll post the lectures on the YouTube channel, so you can, if you want to just review, some of what we said, but probably when we start going into more detail and more complex situation, then you can quickly go on the YouTube channel and review the lecture. Okay, so the YouTube channel will, of course, is my name, and just look for current guidelines, and you can just review the lecture. Okay, all right, good night.